The pancreas is a digestive organ located in the back of the upper abdomen, behind the stomach and liver. It joins the first portion of the small intestine, known as the duodenum, through a duct that drains digestive fluid into the duodenum. There are 5 main regions of the pancreas: the head, the uncinate process, the neck, the body, and the tail. The pancreas has 2 functions. One is an exocrine organ, where cells produce enzymes and the digestive fluids that are released through the pancreatic ducts and help break down food into useful nutrients that can be absorbed by the small intestine. Cancer much more commonly forms in the cells of the exocrine portion of the pancreas. The second function is an endocrine organ, where groups of endocrine cells, known as islet cells, produce important hormones such as insulin, glucagon, gastrin, and somatostatin. These hormones are released into the bloodstream and help regulate important functions throughout the body. Insulin, in particular, is very important in helping to regulate the uptake of blood sugar, or glucose, into the body's cells, so maintaining a healthy blood sugar level and fueling the body's cells. Cells within the pancreas grow to form lesions or abnormal changes that are benign, or form lesions that are precancerous, which will eventually develop into a cancerous tumor. There are several types of cancerous tumors that are derived from cells in the exocrine or endocrine portions of the pancreas. The most common form of pancreatic cancer grows from exocrine cells in the pancreatic ducts and acini, or glands, that produce digestive enzymes. This form of cancer is known as pancreatic adenocarcinoma. It accounts for about 95% of all pancreatic cancers. Other exocrine pancreatic cancers include cystic cancers, which are fluid-filled cancerous lesions, as well as several uncommon forms such as squamous cell carcinoma and adenosquamous carcinoma, both derived from pancreatic duct cells. Signet ring cell carcinoma, a rare form of adenocarcinoma, ampullary carcinoma derived from the ampulla of Vater, and undifferentiated carcinoma. Endocrine cancers, also known as neuroendocrine cancers, account for about 5% of pancreatic cancers. Many of these tumors are benign, yet some are malignant. These develop from the islet cells or the associated nerve cells of the endocrine portion of the pancreas. These types of cancerous tumors include carcinoid tumors, gastrinomas, insulinomas, glucagonomas, somatostatinomas, and other rare cancers. While there's currently no known specific cause of pancreatic cancer, there are risk factors that increase the likelihood that pancreatic cancer may develop. These risk factors include smoking or tobacco use, obesity or being overweight, certain industrial chemical exposure, age. A person's risk goes up as they age, especially over 45, gender. Men are more likely than women to develop pancreatic cancer, race. African Americans have a slightly increased risk as compared to whites, family history. Sometimes it appears to run in families, inherited genetic syndromes, gene mutations passed from parent to child, diabetes, and chronic pancreatitis, which is lasting inflammation or swelling of the pancreas. Pancreatic cancer can grow for a while within the pancreas before causing any noticeable symptoms, which is why early pancreatic cancer often goes undetected. However, there are several symptoms that do occur with pancreatic cancer. These include jaundice, where the eyes and skin have a yellowish tint, the skin is itchy, and stools have a greasy appearance, all caused by the buildup of bilirubin. Bilirubin is part of the bile that is produced in the liver but cannot be released when the common bile duct is blocked. Other symptoms are abdominal or back pain, bloating, weight loss and poor appetite, and nausea or vomiting. Though each of these symptoms can be caused by a variety of conditions, it is important to visit your doctor when any of these symptoms do occur. Because the pancreas is deep in the body, a growing pancreatic cancer tumor can be hard to detect at an early stage. There are also no early screening tests routinely recommended by doctors. However, after a doctor has completed a medical history and physical exam, and it is found that a person has a risk factor for developing pancreatic cancer, such as family history or a genetic syndrome, certain tests may be performed, such as a genetic test. For people with a strong family history, an MRI scan or magnetic resonance imaging or an endoscopic ultrasound may be used to look at the pancreas. Endoscopic ultrasound is a minimally invasive procedure where an endoscope is introduced into the digestive tract through the mouth and placed into the duodenum next to the pancreas. Then, the ultrasound probe on the tip of the endoscope is used to make detailed pictures of the entire pancreas, ultimately looking for cancer. Research studies have shown that EUS, or endoscopic ultrasound, is able to detect cancers not seen by MRI or CT scans. Therefore, some doctors have advocated for its use to screen for pancreatic cancer in high-risk patients. During the diagnosis of pancreatic cancer and after the diagnostic tests are performed and analyzed, the doctor will determine the stage of development that the cancer has reached. This is known as staging the cancer. Overall staging, which is similar for many cancers, is rated on a scale from 0 to 4, where 0 means the cancer is within the organ, and 1 through 4 designates the amount the cancer has advanced and is spreading. Another staging scale used for pancreatic cancer is the TNM system, where 3 key pieces of information are determined: the T value for tumor, N value for lymph nodes, and the M value for metastasis or spreading to distant sites. Each letter will have a value applied to it, which will help determine the clinical stage of the cancer. This information will help the doctor determine how to personalize the patient's surveillance or continued observation and treatment. Survival rates give an indication of what percentage of people with cancer will be alive after a certain period of time, often 2 to 5 years, as compared to a person in the overall population. 5-year survival rates are classified for patients with localized cancer where no cancer has spread beyond the pancreas, regional metastatic cancer where the cancer has spread to regional lymph nodes, and distant metastatic cancer where the cancer has spread to distant organs. For localized cancer, the 5-year survival rate is 34%. For regional cancer, it is 12%. For distant cancer, it is 3%. While the total overall 5-year survival rate for pancreatic cancer is 7 to 9%. After careful analysis of all of the data collected during the diagnostic stage and a full understanding of the unique characteristics of the individual patient, treatment options will be discussed with the patient and an individualized treatment plan will be developed. Importantly, precise staging is key for appropriate treatment, and when possible, surgery is the treatment of choice. Surgery occurs when a trained pancreatic or oncologic surgeon removes the cancer, which is complex and requires a high degree of proficiency. Though the type of surgery is dependent upon the stage, the location of the cancer, and is typically not performed if the cancer has metastasized, as is the case of adenocarcinoma of the pancreas. Ideally, if the pancreatic cancer has not spread outside of the pancreas, the tumor can be completely removed. However, even after removal, the cancer can reoccur. Therefore, chemotherapy is advocated. And recently, as a result of data from research studies, giving chemotherapy before surgery has also been encouraged. Unfortunately, the vast majority of pancreatic cancers may not be able to be completely removed when discovered as a result of local involvement of major blood vessels, and therefore may require additional or alternative treatments. These treatment options may include chemotherapy, which is anti-cancer medicine given intravenously or as a pill that attacks cancer cells throughout the body, which can be given at various times during treatment. Targeted drug therapy, which is medicine that targets parts of the cancer more specifically than standard chemotherapy and can be used in association with chemotherapeutic medicine. Immunotherapy, which are medicines to help stimulate the body's immune system to attack the cancer cells. Radiation therapy, which uses high-energy X-rays that are focused on the cancer to reduce its size before or after surgery. CyberKnife, also called stereotactic radiation therapy or SBRT, is a high-intensity radiation therapy in the endoscopic placement of fiducial markers around tumors and radiation oncology expertise in the delivery of this high-intensity radiation therapy. SBRT has the advantage of decreasing the total number of treatments and allowing for greater intensity per treatment to treat and reduce the size of tumors in the pancreas. Importantly, SBRT also has fewer side effects. Other treatment options include ablation therapy, which is a technique a doctor may use to destroy the cancer without removing it in order to reduce its size or reduce symptoms, and pain control management, which are typically medicines or endoscopic procedures used to treat pain associated with pancreatic cancer growing and pushing on the nerves and causing severe pain. Additionally, blockages to the bile duct or small intestine may occur with pancreatic cancer. These can now be treated by minimally invasive endoscopic surgical techniques, such as the placement of stents and performing endoscopic bypass. These are technically challenging procedures, but can provide relief with less morbidity and can also cause less delay to chemotherapy treatment for the patient. Depending upon the circumstances of the patient, these treatments can be performed before surgery, which is called neoadjuvant treatment. They can also be performed after surgery, which is called adjuvant treatment. Or they can be performed when the cancer is metastasized or surgery is not an option, which is called palliative treatment.